This computer.
Do you want me to start now, or we can wait like for?
I think it's a good number of people online now, but I just maybe, Nina, I'll just introduce the topic and maybe put some context around it. As I said before, these meetings will welcome everyone to Pediatric Teaching today. I'm Trevor Duke, and we have a guest speaker today, Dr. Nina Putri, and we also privileged to have many members of the Indonesian Pediatric Association and the Indonesian College of Pediatrics present. So we thank our Indonesian colleagues for attending today. They have a very important story to tell. I think they've had some experiences lately. We're going to talk today about acute renal failure and encephalopathy in children, and talk about the recent outbreak in Indonesia and the possible causes and the need to be on alert for the possibility of poisoning causing kidney failure. So just to as one slide of background, there've been so far, at least up until last week, 131 cases of children with acute kidney injury, acute renal failure in Indonesia in 14 provinces, and with a mortality above 60%. And these have all been cases reported by the people attending online today, by the members of the Indonesian Pediatric Association. But we'll talk as we go on about other outbreaks that have occurred with this syndrome in India, several outbreaks in India, but also in Nigeria and Bangladesh and in the Gambia, and then a historical perspective of going back about 80 years to the first reported cases of acute kidney injury related to what we think is implicated in this outbreak. I'm going to stop sharing now and ask Dr. Nina Putri, who's a paediatrician from Jakarta, to present a case which illustrates some of a typical child who has this problem. Nina, thank you very much for preparing this case and for presenting to us today. So I'll stop sharing, and you can share your slides.
Okay, thank you, Prof. Trevor, for having me here, and good afternoon, everyone. And also, I would like to acknowledge my senior professor from Department of Pediatric in Cipto Mangunkusumo Hospital, as well as the Indonesian Pediatric Society and Indonesian College of Pediatrics. So, yeah, I will start my presentation with this. So I will discuss further with Professor Trevor Duke according our case today about a story about children with sudden loss of urine in low middle income countries. But I want to disclosure, I'm not a nephrologist nor an intensivist like Professor Trevor Duke. I'm just a curious pediatrician. So the first case is a 10-month-old boy with body weight 8.3 kilograms with body weight 70 centimeters. And he started become high fever at 12 days prior to admission. At the time, parents just treat him with paracetamol. And then at the time, parents noticed that he had darker urine and no urine, and then brought to district hospital. And that time, in the district hospital, they treated with fluid therapy because they think that probably it is dehydrated, and then treated with furosemide because there is no urine after giving the fluid treatment, and then the patient still having no urine. And then 5 days prior to admission, the doctor in district hospital noticed that this patient becomes swollen and body weight increased more than 1 kilograms, and then referred to our hospital for further workup for acute kidney injury. And in our hospital, we realized that this patient having acute kidney injury based on the anamnesis, physical examination and lab, and I will present it later on. And then in our emergency department, because at the time there's no space in PICU, and then we do the hemodialysis at day 1, 2, and 5 after admission. But unfortunately, the patient become deteriorated and intubated because the patient got unconsciousness and then admitted to the PICU. So at the presentation, actually, he's still alert with GCS around 14, no stridor, no desaturation, but we realized that there is a rales in both lung. And then at the time, we noticed also there is a hypertension. You can see here that blood pressure is in the percentiles 95 plus 12 and plus 30. And then we also noticed there is an edema, no fever. He looks quite pale, but his nutritional status is normal. So we check several things because we have previous experience with our patient before. So we check for the CBC. We see that anemic, and then we also noticed that there is a increasing a little bit of thrombocyte. It is normal, not increasing, but there is no thrombocytopenia at the time. And then increased monocyte, procalcitonin, and also CRP is not really high. We also noticed that patients have increased D-dimer around 8,000 in our units here. Probably is quite different from your countries. And then slightly increase of ferritin, increased troponin I, CK, CKMB, and also C3. And we do massive screening for infectious disease because at the time we think that it probably related to the infectious disease. And then we only found that the blood culture is contaminated, Staphylococcus epidermidis with PCR of SARS-CoV-2 negative, antibody of SARS-CoV-2 IgG is positive. And we did the nasopharyngeal aspirate, and then we reveal there is an enterovirus. And we screen also for hantavirus, leptospirosis, and rickettsia, it's all negative. And then we also noticed that there is a increasing of urea in blood, and also creatinine with GFR is very low, it's 4.7, with increase of potassium, and also increase of EST/ALT with the acidosis, metabolic acidosis with high anion gap is 18.5, with low bicarbonate, and best excess is around minus 15.9. So I will not discuss about the treatment, but at the time we think that probably it is related to post-COVID-19, and then we treat the patient as the MIC at the time, and we also administer the antibiotic because we are also afraid of the infection or septicemia, and also we treat the patient with IVIG methylprednisolone, and we do the hemodialysis, giving the anticoagulant at this patient. Unfortunately, this patient is not survived. So I will continue for the second case. So I choose the first case is PCR negative patient, and the second case is positive of SARS-CoV-2 patient. So the second case is a girl, 7 months of age, body weight 7.5 kilograms, and then came to our hospital with chief complaint lethargic in the past 3 days prior to hospital admission. And then 1 week prior to admission, she got a fever 37.9 with non-productive cough. At the time, parents brought to the clinic, given antibiotic and paracetamol, and fever subsided the day after. But 3 days prior to admission, parents noticed that there is vomiting 2 to 3 times a day, only small volume, but patient become lethargic, anorexic, and irritable. And then parents also noticed 2 days prior to admission, the child become less urine output, and 1 day prior to admission brought to ER because more lethargic, lesser urine output. And at the district hospital, they screened for the kidney failure and then referred to our hospital. So at our hospital, she is unconscious with low GCS and also looks small, and then intubated with severe metabolic acidosis, and at the time treated with bicarbonate. And we screened for PCR, and it is positive, both for PCR of SARS-CoV-2 and also positive for antibody of SARS-CoV, and transferred to PQ isolation ward. But I want to stress that both of the patient has no past illness and unremarkable past illness before, without the same family illness history of the same illness in the family, and actually they are growing quite well, and then complete immunization and no additional illness before. At the presentation, she is intubated on sedation, on emergency room, no paresis nervus cranialis, and also still positive of physiological reflex, negative pathological reflex, no fever at the time, blood pressure is still normal, but slightly tachycardia, and then have edema in the palpebra, no acid test, no icteric. And at the time we put on the ventilator, and the other is still normal, the heart, and there's no bleeding. And we noticed that the urine only 0.2 milliliter per kg per hours. And at the presentation, we see the CBC, there is slightly anemic, and then there are thrombocytosis of 500 plus, and then also leukocytosis with predominantly neutrophil. And we see also increasing of CRP, and then also increasing APTT, D-dimer slightly increased with high CK, CKMB, troponin I, ferritin, also other inflammatory markers such as preseptin, IL-6, and also, yeah, that's the result. And for the biochemistry, we found the patient is having metabolic acidosis with high potassium at 6, and then also with high anion gap. The blood urea is 200 plus, creatinine is 12.4, with GFR very low, 2.1, slightly increase of EST, sorry, forget it's still in bahasa, EST, ELT. And we also screen for the other infectious disease such as HIV, hepatitis marker, and we found that the PCR of SARS-CoV-2 positive, but I will disclose the CT is around 28 with negative qualitative antibody, but positive for the quantitative antibody, and blood culture negative, urine culture is E. coli at the time. And this is the radiology findings normal, and we did the ultrasound. We see that there is an elevated resistance index in bilateral renal arteries, right and right segmental artery, with biphasic pulsatile observed on bilateral renal vein with differential diagnosis is venous congestion. And there is a acid test in hepatorenal region, and there is no other finding, and we exclude there is no congenital abnormality of the kidney or urinary tract infection. So at the time that patient also we treat as the septicemia, and then also we do the hemodialysis, giving the IVIG, and unfortunately the patient is not survive also. So in brief summary, in our case, in our hospital, we see that the patient previously healthy children without evidence of congenital acute kidney injury, and also there is no consistent data with hemolytic uremic syndrome, and without history of hypovolemic shock or hemodynamic instability, because the loss is not that significant, with usually come with the prodromal symptoms, fever, GI tract symptom, respiratory symptom. And also, we noticed that the water loss is not significant, but patient at that time end up with anuric and also oliguric with reduced GFR. And typically, we observe that the patient at the presentation usually alert and then become unconsciousness because within 5 to 7 days. And we also noticed at the time patient having evidence of coagulopathy with high D-dimer, increased transaminase, and we do massive screening for infectious disease with tropism in kidney, such as Hanta, cirrhosis, rickettsia, and dengue. It's negative, and also we did the rectal swab, nasopharyngeal aspirate, but there is no consistent pathogen that can explain the etiology of acute kidney injury in children. And we observe also positive antibody of SARS-CoV-2 in 58.7%, only 3 having positive SARS-CoV-2 PCR. And also we did brain CT and MRI, which is normal, no press. And we did kidney biopsy. We found that acute tubular necrosis, there is no glomerular disease. And in our hospital, we concerned about increasing case since the peak is in August, September. We never see this kind like patient even though with COVID-19, we haven't seen the patient with severe acute kidney injury if there is no comorbidities. And but at the time we do the massive screening for infectious disease, we think that it's probably related to post-COVID-19 syndrome. Probably it is second hit, probably it is multi-inflammatory syndrome in COVID-19, but most of our treatment is not succeeded. And we just realized that there is a report from Gambia, from WHO alert, and we see that probably it is related to intoxication. But currently, we still waiting for the result of the intoxication screening. We don't really know if it is really intoxication or not. But happy to discuss with you all about our diagnosis. Probably you have further comment, Professor Trevor, and then we also see in the literature what can be an etiology of the acute kidney injury in tropics, and it can be include infection, toxin, poisons, and also the other things such as immunology. Thank you, Professor Trevor.
Okay, thanks, Nina. That's a great presentation of two cases, and you and many colleagues have seen many more of these cases. So thank you very much for that. And I just thought I'd just make some brief summaries about the situation, and then maybe we can have a discussion. I'll just go through it up to where you were. Oops. Okay. So if I'm not mistaken, the cases that have been seen have presented with usually a preceding febrile infective illness. It could be COVID, it could be some other respiratory infection. And in the context of the pandemic, there's been a high rate of COVID antibodies, COVID positive recent infections. But there's also commonly been a second infective agent, some other virus or a bacteria isolated, not universally, but that's been what's been described. That on transfer to your hospital, the patients have had signs of kidney failure with urea and creatinine levels often 3 times higher than the normal range. And they progressed within 3 to 5 days to anuric renal failure and neurological deterioration, which has been relatively sudden. They've often presented conscious and then progressed to lethargy and seizures and coma. And so we have this syndrome of children with a prodromal illness presenting with anuric renal failure and edema, and then developing coma. In terms of the cardiovascular system, what I understand is that most of these children have warm peripheries and they have edema, and they have the early signs of hypertension when they first present. And their edema could be because of the capillary leak syndrome that they have. There's some suggestion that they have hypovolemia as well. So with some on ultrasound showing a collapsing inferior vena cava, suggesting some degree of intravascular volume depletion despite their edema. So that may suggest capillary leak as part of the mechanism. And some of these patients have had hyponatremia, but that's when they get to the referral hospital, and perhaps that's because of high levels of ADH secretion or their progressive renal failure, or because of the fluids they've been given in the previous hospital, which are often fluids with low amounts of sodium. But their hypertension generally progresses. Nina, as you described, they often have this high D-dimers and a procoagulant state, not always at the time, but usually present with a high D-dimer and thrombocytosis, but their coagulation is otherwise usually normal. They may have some signs of infection, some virus isolated. Their white cell count may be mildly elevated, but typically their CRP is not very high, so not clearly sepsis, and certainly not septic shock like we're used to seeing perhaps, or not clearly shock from multi-organ failure like in MISC. Many of the cases that have been described in other outbreaks have proteinuria, so 2 to 3 plus proteinuria, and mild degree of hematuria. And many of these patients have a a moderate transaminitis. Their ALT, AST is a bit high, but no evidence of severe synthetic dysfunction like a severe coagulopathy with a high prothrombin time or a high ammonia level. And their neurological deterioration may be because of the progressive uremia. Some, it might be hypertensive encephalopathy, like this syndrome of Press from hypertensive encephalopathy, or it may be the effect of a poison itself that affects both the kidneys and the brain. And I think that we'll focus a bit on that last, the last possibility. The possible causes, as you've described, an unusual presentation of this post-COVID hyperinflammatory state, the MISC, that we've seen quite a lot, but we've never seen it just affecting the kidneys without shock. I think we've all seen some degree of renal impairment, some kidney problems in children who have shock with MISC, but not before with just causing acute renal failure and hypertension. So that, in a way, that makes it a less likely scenario. But perhaps the more likely scenario, Nina, as you said, is some sort of poisoning. And I just want to go back to some of the, you mentioned the Gambian outbreak that occurred recently. This was only this year in 2022. And there was an outbreak of acute kidney injury affecting over 30 children. And the cause of that was probably diethylene glycol poisoning that was in cough and cold remedies that were made by a manufacturer in India called Maiden Pharmaceuticals in Haryana in India. And that has been proven epidemiologically, I suppose, rather than proven in terms of the finding the ethylene glycol in the substance. But it's consistent with other outbreaks that have occurred in previous years, in 2006 in India, in the same region, in Haryana, and also in Pakistan and Nigeria and Bangladesh. And diethylene glycol, as you mentioned, is sometimes found as a contaminant in cough and cold syrup remedies and in paracetamol that's sold over the counter. Now, as you emphasised, Nina, it's not proven in your cases, but it just looks remarkably like that, as I think we've discussed. I just wanted to talk a bit about diethylene glycol and why it might occur in these cough and cold remedies. And the story really goes way back to 1937, when the first cases of ethylene glycol poisoning were reported. Diethylene glycol is a sweet tasting solvent, and it's very cheap and widely available. And it's sometimes used as a replacement or an addition for glycerol, which is an important, well, a common part of the solvent that's used for paracetamol. To make up a syrupy medicine, the paracetamol is mixed with something, and it's usually mixed with a solvent or a glycerol substance. And some companies have in the past contaminated their glycerol with diethylene glycol. And previous studies said that the toxic dose was 1 mil per kilogram of 14% diethylene glycol. And most of the assays that have been done finding diethylene glycol in paracetamol or other medicines have found somewhere between 14 and 17% diethylene glycol. So you don't need to take much, but perhaps if a child is given several doses of paracetamol over several days, that then there's a cumulative effect that will cause kidney failure and encephalopathy. There are some reports in the past of subclinical poisoning. So when there's been outbreaks of major deaths from acute kidney injury, they've also looked at children who were sick but didn't die. And the suggestion is that they've had smaller doses and they may have become a bit sick but not got kidney failure. This is why diethylene glycol, I've tried to explain here why diethylene glycol, when it's added to medicines or when children ingest it, will cause kidney failure. And it's diethylene glycol, as I said, is a solvent, and it gets converted by alcohol dehydrogenase, which we all have in our liver, alcohol dehydrogenase. It's converted to two substances. First of all, hydroxyethyl acetate acetaldehyde, and then that's converted further to hydroxyethyl oxyacetic acid. And it's the hydroxyethyl oxyacetic acid that causes kidney toxicity. And it typically causes, as you said, Nina, the acute tubular necrosis, not so much glomerular injury, but acute tubular necrosis. And there are other sorts of poisoning that's a bit similar to this. So if any of you have heard of, some of you may have heard of ethylene glycol. Ethylene glycol is another substance that's a bit like diethylene glycol. And ethylene glycol is found in antifreeze, which is a substance in some countries that are very cold. People put in their radiators to stop the engine freezing up. And in some countries, there have been outbreaks of poisoning from ethylene glycol, or there are some attempted overdoses or suicides with ethylene glycol because it also causes severe kidney failure. But the substance most commonly contaminating medicines in the past in these outbreaks has been diethylene glycol. As I said, that it's metabolized to the toxic compound. So it's not toxic intrinsically, but it's metabolized to these toxic compounds. A bit like ethanol, alcohol, if we drink alcohol, then alcohol dehydrogenase is the same enzyme we have in our liver that metabolizes alcohol to formaldehyde and glycoaldehyde. And they're also substances that will be toxic in overdose. The reason why that's important is because we have if we didn't have alcohol dehydrogenase in our body, then we wouldn't make the toxic derivatives that would cause kidney toxicity. But it also provides a mechanism for an antidote. And we'll get onto the antidote in a minute, but that's the mechanism by which kidney toxicity occurs. The treatment is, as you mentioned, Nina, the treatment of acute kidney failure. So fluid restriction to maintain intravascular volume so that children don't get pre-renal failure as well. Sometimes that will require central venous pressure monitoring or monitoring of the inferior vena cava just to see what the intravascular volume is. And that should be corrected if there's evidence of intravascular volume depletion, even if there is edema, because it's still possible to have both edema and capillary leak and the child still be hypovolemic. Try to control the normal blood pressure to probably the upper limit of normal for their age, but not higher than that, so that they don't get encephalopathy. And then frusemide, as you said, as being the fundamental treatments of evolving acute renal failure. The specific treatment, if you think that the child may have had diethylene glycol poisoning, is this medicine called fomepizole. And fomepizole is an inhibitor of alcohol dehydrogenase. So if I just go back to this, if you give fomepizole, it inhibits alcohol dehydrogenase, so therefore it doesn't get to be converted to the toxic compounds. That's one way. Now, fomepizole is not very widely available, but the other way to do it, the other way to prevent it, is to give ethanol, because it acts as a competitive antagonist for alcohol dehydrogenase. If you use up all your alcohol dehydrogenase, then the ethanol will be converted to formaldehyde, but the toxic compound, a very toxic compound, won't be converted to the toxic metabolites. So previously in children who've had antifreeze poisoning, we've used intravenous ethanol to prevent them metabolizing the ethanol to the toxic compounds, and it works quite well. But fomepizole is a preferred antidote, that's for sure. It's possible that if you don't have intravenous ethanol, of course, it's not safe to give standard ethanol or anything. It has to be medicinal, medically prepared ethanol. It would be very, very dangerous to give normal ethanol, give it intravenously. But it is possible that if you don't have fomepizole and you don't have IV ethanol, medical IV ethanol, then using nasogastric alcohol could also work in the same way as a competitive antagonist or competitive inhibitor of alcohol dehydrogenase. So using nasogastric alcohol, whether it's whiskey or some other form of alcohol, in such patients may prevent them getting the toxic metabolite that causes kidney failure. When a patient has renal failure, then renal replacement therapy is the only supportive therapy. It's not curative, but it's supportive. And we've talked about the mechanism of, or at least the extent to which you have to do renal replacement therapy. And in the past, for patients who've got ethanol poisoning, we've had to do this thing called continuous veno-venous hemofiltration. When patients just get peritoneal dialysis, that doesn't tend to be as effective as veno-venous hemofiltration. I won't go into all the details of CVVH, but that's really the only way you can support the kidneys when they've got progressive and severe renal failure. It's possible that some other medicines like N-acetylcysteine could also protect the kidneys as they're failing from this type of poisoning, but that's speculative. N-acetylcysteine is sometimes used in other forms of drug-induced kidney injury, and it can be effective. When you mentioned that these patients have a hypercoagulable state like thrombocytosis and a high D-dimer, and it's possible that using aspirin might prevent some of the effects of the inflammatory state on the kidneys, although it depends on what the cause is. It's useful to have high magnesium levels, so I tend to give magnesium to patients who have impaired kidney function, who have progressive acute renal failure. And then if you're going to give steroids or you're going to give other IVIG for the possibility that this is MISC, then you need to give some nasogastric feeding and avoid other nephrotoxic agents. I'll just go back now to the history of diethylene glycol poisoning, and the first cases were reported in the US in 1937, and that was by a company that was making sulfanilamide, which is one of the earliest sulfonamide drugs, like cotrimoxazole today, but sulfanilamide, it was an early antibiotic, and that company had made the sulfanilamide and used the diethylene glycol as the elixir and the flavoring agent, because it's a sweet flavoring. And there were many adults, this was mostly used in adults, or many adults who developed acute kidney failure and died because of that. That was the earliest reports. And then subsequently in the US, there were laws passed to prevent the use of diethylene glycol in the manufacturing of any medicines. But unfortunately, that's not the case in many countries, and the unregulated production of some of these proprietary medicines, cough and cold remedies and paracetamol, continues in many, at least in some countries. And the most, I suppose, the location that has been most implicated is Haryana in India, where, as we reported, several outbreaks that occurred in 1998 and 2006, but also outbreaks in Nigeria and Bangladesh and Pakistan, and in the Gambia, which was based on what was thought to be cough and cold remedies also from that region in India. Of course, there's many pharmaceutical manufacturers throughout India, and very few of them would do this, but this is what's been reported in recent years, and that's what led to WHO this year putting out a medical alert and a product recall for all such agents. I was struck by in 1998, one of the earliest reports was diethylene glycol poisoning in India. The Guguron is a location in Haryana around Delhi, and I thought the description in the discussion was very similar to what people are faced with at the moment, because the investigators said at the beginning of the investigation, we never imagined that contaminated medicine was causing acute renal failure in children. Virtually all cases of unexplained acute renal failure in this series began with an acute febrile illness with or without watery diarrhea or mild respiratory symptoms, and quickly ended in the complete shutdown of the patient's kidneys. None of the children were dehydrated or in hypovolemic shock when admitted to the hospitals in Delhi, and most did not respond to peritoneal dialysis and conventional treatment for renal failure. And I thought this was very reminiscent of the other cases that have occurred earlier this year in the Gambia and potentially those ones that you faced in Indonesia. So the purpose of today's discussion, in a way, is to try to communicate to other paediatricians, and this forum is really a paediatric teaching forum for paediatricians in Papua New Guinea and the Solomon Islands and in Vanuatu in Oceania. And it's clear that all countries that import such medicines would not be immune from this type of thing. So if we are alert to children who might have acute renal failure as possibly being due to such poisoning, but as you say, Nina, keeping an open mind about the causes, then we'll do well. Today, there has been a circular from the Department of Health in Papua New Guinea calling for an urgent recall and disposal of such medicines, and highlighting that the medicines that were implicated in the Gambian outbreak, not referencing the Indonesian outbreak, but just saying that these medicines were implicated in Gambia and may have been sent to other countries as well. And certainly in many countries, there's unregulated importation of such medicines to be sold in private pharmacies, and that's probably where most of this arises from. So that's all I wanted to say, and I'll stop sharing my slides. But as I said, I think it's very good for countries to share this information, and not to jump to conclusions, but just to be alert to children that might have acute renal failure and what to do about it. Maybe we'll, if Nina, do you have any other comments, or any of our other Indonesian colleagues have comments that you might want to share? Please do so.
Yeah, Prof. Trevor, probably my Indonesian colleagues or the other participants.
May I ask question, Professor Trevor? Hello, good morning or evening. I'm Dr. Karyanti. Is my sound audible? Is my voice? Yes, it's fine. Okay. Thank you very much for the nice presentation from Dr. Nina and Professor Trevor, who have given us a clue in other insights about the drugs, that can cause the acute renal failure. But in our case, we are still exploring the cause of the etiology which caused the acute renal failure. But from the FDA in Indonesia, the content with the ethylene glycol is not permissible from the FDA in Indonesia. So we have confirmed the form, but we still, of course, will investigate the drug's content which contains that. But if it's not the cause of our case, the same etiology, I would like to ask your insight. What can or advice you can give us to help these children? Because we do meet these children. Usually they have a past COVID infection. The 3-4 cases that I'm facing in the P2, we have cases who had SARS-CoV before with a high anti-SARS-CoV and a high diaedema, and also high ferritemia, and with the acidosis metabolic. And most of those cases of the parents who are not aware if they get COVID or not before. But from my experience from the infectious disease for 22 years, the etiology is different in all of our acute renal failure. So it might be caused by from the other publication which did a biopsy. It was found that the SARS-CoV nephrotropic is in the tubulus, and there were 2 child who had renal biopsy. I don't know if there's more, but in our case, we have the impairment in the tubular side. So these children who have COVID before might have this acute renal failure because of the SARS-CoV in the tubule. But because of a second hit of any infection, it can be viral, it can be bacterial, or even a fungal, because most of the cases are referred from other hospital and has been given the antibiotic, and they come in the cases with a gram-negative bacteria and also a fungal in their blood. In our experience, if there's a fungal in the blood, invasive candidiasis or invasive fungal, they are usually immunocompromised stage. And these child came with anuria or oliguria, and then they acidosis metabolic, which caused them to be ventilated, and the impairment of consciousness becomes dramatically decreased. And one of our case even have bleeding manifestation. Antibiotic was given cephalosporin as our protocol before. They are usually given cefotaxime or ceftriaxone from the other hospital, but we use an antibiotic which is not nephrotoxic, cephalosporin as our protocol. And but if the child deteriorates, so the nephrologist will do the hemodialysis with their sophisticated tools, and also plasmapheresis was also done. But still, the weird thing is that if before we thought it was MEIC, and so the protocol of MEIC was already given, like steroid with a low end dose, and then with IVIG, but it didn't get better. Antibiotics already given. If it's bacterial sepsis, in my experience, if we have the right, correct antimicrobial, usually sepsis will get well. But here in our cases, antibiotics given, and even a high dose post-med steroid was given and tried, but it didn't get better. And when there's impaired consciousness, an MRI was done, but there's no clue of any impairment. So it looks normal, no thrombosis, no stricture. So this is so weird. This terror the patients because so quickly and they die. We offered this patient usually if first came to get the biopsy and also autopsy, but I don't think the parents are until now have agreed the autopsies. I think we have to work together. I think with the other pediatrician here, with the intensive care unit, the nephrologist, all of us must work together. And we need your insight or suggestion. What can we do to help these children before we don't know the etiology? Because these drugs are not even permitted from the FDA in Indonesia. Thank you, Professor Trevor.
Well, thank you very much. I mean, you've described the complexity of the situation, I suppose, especially when you're not seeing the patients right at the time they first present, but seeing them after they've been treated in another hospital. And I agree with you both that it's important to keep an open mind about the cause and also to provide supportive care. And I think that's what you've been doing, isn't it? If a patient's in acute renal failure, no matter what the cause, then you have to provide some supportive care to the kidneys, and it's whatever you can do. If all you can do is peritoneal dialysis, then that's what you do. If all you can do is slow continuous ultrafiltration, which I know you were doing to start with, that's fine. But I guess continuous veno-venous hemofiltration is also supportive care. I think you're doing all the right supportive things, all the different treatments that I mentioned. I cannot imagine any other supportive care you could provide, except perhaps the timing. What may be important is the timing of the institution of such care. And I'm not quite sure whether these patients are getting filtered very late or whether they're getting support for their decreasing conscious state rather late, and what the role of nosocomial infection is. But I think while it's important to keep an open mind and think that they might have a COVID-related illness, keeping an open mind also means they might have a poisoning as well. But regardless of what it was, you just provide supportive care and see if the patient gets better. as best as you can. I think you're doing all the things that I mentioned before in terms of treatment. Yes.
Thank you, Dr. One of my thoughts were that maybe these children had an acute kidney injury because of SARS-CoV, and whether when there's a second hit of any infection which causes dehydration, like vomiting, because most of them come with diarrhea, vomiting, or the tough mostly are diarrhea and vomiting, and 23 to 30% can come with cough, or when they have difficulty in feeding, then they become dehydrated, then the acute renal failure become worsening. I think that was my assumption, but I don't know, maybe other friends from the nephrologist, the intensive care paediatrician can give some insights also. Thank you, Professor Feather.
Thanks. Thank you very much. Yeah, I think you're referring to the possibility of there being a pre-renal component to it. And I think that's important, isn't it? If they have diarrhea and vomiting, then even though they may have edema, they may still be intravascularly volume depleted, and there might be some degree of pre-renal kidney failure. And so ensuring that they have adequate intravascular volume is probably important in the early stages anyway. Yeah.
Thank you. Maybe Dr. Nikan or Dr. Iren, our nephrologist here is Dr. Tapila, Dr. Eva. Maybe can give some insights to what has been done for the children from the nephrology side. There's Prof. Fatini also. Good morning, Prof. Fatini.
Morning, everyone. Probably Dr. Henny can add something. Dr. Henny, are you there?
Yes, Prof. Fatini, thank you. Thank you, Prof. Trevor, for the perspective on our cases. So, as you said that, I'm sorry before because I cannot put my camera on. So currently in nephrology perspective, we've already done kidney replacement therapy in many forms actually. Firstly, we tried intermittent hemodialysis and we see that it didn't work because, as you said before, that there's possibility of edema with intravascular depletion. So during intermittent hemodialysis, we found a lot of patients got hypotension. And then we also performed peritoneal dialysis to one patient, and it also didn't work because the ultrafiltration was not very good. Although the patient got the diuresis back, but the patient was not regain his consciousness. And then we also tried the CVVH-D to some patients. And we remember that some of the patients, maybe 2 or 3 patients, also regain the diuresis and not regain the consciousness. Currently the CVVH-D is very limited because we don't have any manpower to do that, and also limitation in the dialyzer availability. So currently we manage all the patients with combination of CVVH or sustained low efficacy dialysis. So we did 5-6 hours dialysis with very low blood flow, and we remove around 5 to 10 ml per kg per hour of the fluids from the patients to give some space for intensivists to give medications, nutrition, and everything. And we also, probably 2 weeks ago, we did plasmapheresis for 3 patients. We did 1 to 2 cycles of plasmapheresis, I told you before, and we see that after plasmapheresis, we can regain the diuresis, and yet again, we cannot regain the consciousness. I think that's my addition to this case, Prof. Kartini and Prof. Trevor. Thank you.
Yeah, thank you, Dr. Henny. I suppose what we know from other situations where a child has acute tubular necrosis, ATN, from some other cause, then often the renal replacement therapy has to go for quite some time, doesn't it? It's not just a few days, but it may be many weeks, up to 6 weeks before the kidneys come back. So it's very resource intensive to be able to be doing hemodialysis for all of that time. And I think it's most locations wouldn't be able to do that. So it is a big challenge to be supporting such children for as long as they need to be supported. I agree.
Yeah, and we did the CVVH at the ultrafiltration dose of 25 ml per kg per hour, Professor Trevor. Yes.
Yeah, well, that will often be, that will often be enough. And I suppose if you did have patients that that you get in the early stages and they maintain some degree of diuresis, even if it's a small amount, and after 5 or 6 days, so they then are passing urine again, then sometimes that will be sufficient then to change them to peritoneal dialysis and then continue on with PD for a period of time. I guess the concerning thing that you described is that some of the patients got some degree of renal recovery, but no central nervous system recovery. And it makes me wonder whether or not, again, that's perhaps a marker of the toxin, the poisoning, rather than something else going on. Because if they just had acute renal failure, usually patients with acute renal failure, once you dialyze them and get the urea down, then their conscious state improves. If you get their blood pressure under control, you get their urea down, then their conscious state comes back towards more towards normal, and they wake up again. But it makes me concerned that there's another toxin or poisoning going on if their conscious state is not returning to normal when you've done adequate renal replacement therapy for some days. What do you think about that?
Yes, that's what we're been thinking of, because we usually see that the acute kidney injury patients get the renal recovery and the consciousness back, as said, but in these cases we don't, and that's the problem. And I want to ask you, actually, Prof. Trevor, in this ethylene glycol or the ethylene glycol poisoning, if as in the literature, how many weeks or how many days do the patient usually get the consciousness back? Do you have any experience or comments on that?
Well, the only first-hand experience I have is with ethylene glycol poisoning, and that's it's a little different, but where children have drunk antifreeze. But it looks to me from the literature on diethylene glycol poisoning that there are high mortality rates in all the case series. In some of the case series in India, the survival rate was about 20%, 20 to 30%, and so a mortality rate of 60 to 70%. And but I would imagine that you'd have to support these patients for at least a week or so if they got some renal recovery, and then perhaps ongoing for another few weeks. But I don't know about their recovery of their conscious state. Actually, I don't know, and it might be that the mortality rates are so high not because the kidneys can't recover, but because the brain is injured. Have you done imaging on many of these patients in your setting, and what have you found on CT or MRI scans?
Well, on CT scans, most of them we don't find anything. We did one MRA to one patient because previously we suspected on microthrombi, However, we did not find anything. We saw one patient with infarction from the CT and one patient with press.
Yeah, well, that's interesting. I mean, I don't know whether exactly what it suggests. In the previous outbreaks of diethylene glycol poisoning, they haven't had sophisticated investigations. So some of the things that you've described, like the high D-dimers and the high thrombocytosis and other things, I think it's not possible to compare the previous outbreaks because they were often in locations where such investigations were rarely done, including cerebral imaging. So I think this is very important. Your case series is very important to describe. Yeah, I don't quite know what that means. The relatively normal neuroimaging means. Well, I guess what I would hope it means is that there might be some possibility of recovery if you can support these patients over a longer period of time, that they might get some neurological recovery if they haven't had major strokes or they haven't got any other, cerebral edema. If they've got a normal MRI or CT scan, then hopefully you'd get some brain recovery, but they clearly would need support over a long period of time, and they probably need to try the antidote in some form for the diethylene glycol poisoning.
Well, one interesting things that I want to add is that we found 3 patients, because we did plasmapheresis and I don't have any markers that I can use to measure. So I try to check LDH level on our patient who performed plasmapheresis. So pre-plasmapheresis, we found that the LDH level is around 700, 800. And after plasmapheresis, the LDH level is around 200. So I think the plasmapheresis can remove the substance well. Yeah, but again, the consciousness is not getting better.
How long have you been able to continue renal replacement therapy for in such patients?
So the longest time would be for 4 to 6 weeks.
Right.
Now.
Yeah, well, that's long enough to get renal recovery if you're going to get it. Yes, in children who've got ATN, that's usually long enough. So, in those patients that didn't get renal recovery after 4 to 6 weeks, did they also remain unconscious?
Only one patient, I think, that gained the conscious back.
Right. All right. Well, we might this session usually goes for an hour, so we might have to stop there. But it's been a very enlightening session, and I thank you all for your contributions, especially Dr. Nina for presenting the case, and all our colleagues in the Indonesian Paediatric Association. And really the aim of today was simply to discuss these cases and promote awareness of the possibility, if you see children who've got acute renal failure, to think about diethylene glycol poisoning, but also keep an open mind about the other possibilities, including an uncharacteristic and rare complication of COVID. So we may yet, I suppose, find out what's going on in Indonesia in time. But thank you again for your contributions today, and we may stop there. So thanks very much.